Hello, everybody. Thanks for joining the Panamerican Society International Grand Rounds. This meeting has been happening for the last 11 years. I can see a lot of friends here today, as usual. And I'd like to introduce one of our star fellows here at Tele-Rondas Center, Dr. Jennifer Lobb. She has been with us, she's on her second year. And she's going to present a nice trauma case. She's going to generate a lot of discussion, a lot of interaction. I'm looking forward for your presentation, Dr. Lobb. Thank you very much for being here today.
Thank you, Dr. Martos. Thank you so much for allowing me the opportunity to present. I will go ahead and get started, and then I have a couple of slides where we'll stop, and Valeria is going to assist me with getting some input from the panelists. As Dr. Martos mentioned, my name is Jennifer Lobb, and I'm in my second year of fellowship here. I completed my surgical critical care fellowship last year. So I'm going to be discussing a case that we had in August at actually Jackson South, one of the medical centers that we work at, but it's an unexpected complication after a penetrating chest trauma. So we have a couple of learning objectives. So evaluating the injury pattern and associated risk factors for complications, and evaluating unexpected or rare complications that can occur after penetrating chest trauma, and just recognizing that careful review of the imaging can provide diagnosis in complicated cases. So as mentioned, this was a patient that came to Jackson South on August 4th in the evening. I was on call there, and this was the trauma alert. This was basically the page that we received. It was an 18-year-old female who was coming by Air EMS to Jackson South after a reported gunshot wound to the left chest. She was hypoxic to the 80s on transport, but not intubated. She had been needle decompressed in the field by EMS, and she was also hypotensive. So when she arrived to us, she was found to be in significant respiratory distress, saturating in the 80s. So she was emergently intubated for airway protection. And that was the first thing we did. After intubation, we checked decreased breath sounds. She had decreased sounds on the left. We placed the left chest tube, and we got immediately about 300 cc's of sanguineous output after insertion. And then for circulation, we placed a right subclavian introducer, and we started transfusing her. In total, she received 5 units of PRBCs and 2 of FFP for hemorrhagic shock. We were able to interact with her briefly prior to her intubation, and her GCS was noted to be 14. So she was talking but confused. That's the reason for the missing 1 point. She was opening her eyes spontaneously, and she was noted to be moving her bilateral upper extremities, but not moving her lower extremities at that time. And I should mention, as primary survey, as most people who do trauma here know, we were myself and the attending who were on call were really doing the ABC part of this simultaneously as everything else was going on. So we were resuscitating her, and then once we did all of those things, we did our exposure. I have the X's here for the 2 apertures that we found. So we had the reported aperture here. It was really just above the left clavicle. And then when we rolled her and we looked at the back, we found the second aperture actually on the contralateral side of the body in the back. So I'm going to show some images here now. So this is the chest x-ray after the first chest tube was inserted and after the patient was intubated. We still saw some haziness there on that side. So we elected to place a second chest tube. After we saw some haziness, which we assumed was persistent blood products in the chest. We got some output from the second chest tube, but not a lot. After we placed the introducer, we placed the femoral arterial line. After she received the transfusion of the products that we spoke about, we noted that her blood pressure was stabilized. So then we elected to take her to the CT scanner. So this is the second chest x-ray that we obtained after the second chest tube was placed. It was prior to going to the CT scanner. You can see some improvement. I will show in the following slides, I'll show some images of her injuries, but just before I do that, I want to just go through briefly the injury. So a questionable narrowing of the distal left internal carotid artery, and that's going to be important for what happened after she was admitted. But she had a left anterior second rib fracture with a pulmonary contusion, a large left hemothorax, and a left posterior eighth rib fracture and a T7 transverse process fracture. And I want to show some of the images because I think they're important in making the final diagnosis. So here's the CT scan that we obtained. You can see both of the chest tubes in the hemothorax there. This, and I'm showing here with my pointer, this is this questionable, narrowing or lack of flow to the left ICA that was noted on the CT scan. I included this is not the brain CT, but this is actually the CTA of the neck, but I wanted to show this because there is some perfusion here through the circle of Willis that you can see at the time of the initial CT. This is a close-up of her thoracic, her transverse process fracture with the associated rib fracture, and I just wanted to show this. It really gives a close-up of kind of giving us an idea of the trajectory of the bullet track. So I just wanted to pause here. The patient's, been resuscitated, stabilized, and sent to CT scanner, and we have the imaging with the following findings. I just wanted to ask the panelists what you would do next in this situation.
Portland, Dr. Kasim.
Good morning. So, interesting case, and anytime I see a gunshot wound as opposed to a stab wound to the chest, I try to activate my plan A in my mind, what this patient is going to be like and what she will need and what do I have to do to get things in order. So I look at a gunshot wound as a cavitational injury, and what you see outside may not be the same as what is going on inside, and as opposed to a stab wound. What I'm trying to get at is they are two different beasts. So the patient comes in with obvious gunshot wound with a needle in the left chest, I believe, and First thing that I would like to stress to my fellow colleagues or residents who may be in attendance here, make sure that you're putting in the right size of needle. Because of our situation in United States, perhaps not in other third world countries, our patients are pretty big. The needle that we used to deploy earlier on does not go into the chest cavity to do the decompression that you are intending to do. It has to be the right size, put in the right place, and I think the current thought is to deploy the needle intercostal drainage in an emergency situation like this. Should be in the, it's not in the anterior, it's not in the second intercostal space, is the anterior axillary line, and the needle has to be much longer than what we have been using. Keep that in mind. So, moving on, I think the first thing you need to do when a patient comes into the emergency room would be to get a quick chest x-ray and then put in a chest tube drainage, then think about intubating the patient if it is indicated. So, we now have a patient who is obviously showing signs of pneumothorax, and you have a single chest tube in place, and we have been told there is the patient has been stabilized with significant amount of blood and blood product, 5 units I'm told, and FFP, and then the patient goes to the CT scan, and there is suspicious lesion in the left subclavian or left internal carotid somewhere in that vicinity. And the patient has significant opacification of the left chest. And I'm not sure whether there is any evidence of any cardiac injury. So I think ultrasound would have been my first modality of investigation before sending the patient to the CT scanner to make sure the patient does not have pericardial effusion.
Mm-hmm.
You never know how this bullet traverses from the left to the right. And obviously there is injury to the left subclavian, and there is aperture on the right side. So the question is, does the bullet traverse the mediastinum? If so, is the mediastinum involved? So your mind begins to wonder, this is going to be a complicated case. And if the patient did indeed have a bullet wound on the left and going to the right side, and then you start thinking about injuries to all the vital structures in the anterior or posterior mediastinum in the upper part of the chest. And there comes the play to the bronchus, trachea, esophagus, and also the lymphatic drainage system, which is on the left side as well. Keep that in mind. So I think this patient, from what you're telling us now, probably will require help from an interventional radiologist or a vascular surgeon to have a good look at that left subclavian to see if the patient needs to be endovascularly treated first before going for an open thoracotomy, which may become necessary. So as long as the patient is stable, clinically stable and hemodynamically stable, I think you have some time to play around to see what the next maneuver is going to be. But do feel free to call in your vascular surgeon attendant and see what he is thinking. And in the meantime, you need to get ready. The patient may have to go to the operating room, mainly to stop the bleed if she's still continuing to bleed and becoming hypotensive. So I will stop there, and I will let the rest of my colleagues say something so I can ponder about this case. Thank you.
Thank you, Dr. Kassim. Dr. Antraj, Baghdad?
Yeah, so I gather there was just the lesion, the reduced flow to the internal carotid, not the left subclavian.
Correct.
Unless I missed something. Okay, all right. And then I was wondering why, when before you showed the entry and exit wounds, why you placed the introducer in the right subclavian as opposed to the left. I tend to prefer the left side because there's a gentler curve from the subclavian vein into the superior vena cava, and you already have a chest tube on that side, but I guess you were concerned based on the trajectory of the bullet, possible injury to the subclavian vessels, artery and vein. So that explains why you did that. So
right.
My concern would be, and I think you probably ruled that out with this, even though this wasn't a CTA, that there was no injury to the left subclavian vein or artery, and the perfusion, the pulses in the left arm are normal. The blood pressure is the same on both sides, or right and left. Is that right?
Correct. Yes, sir.
Correct. Okay. And also, as you said, the patient was alert, moving all four extremities, and you showed the circle of Willis. So presumably that reduced flow is an incidental finding, probably not clinically significant. And with all of that, and assuming the patient remains stable, at this point, I think you can observe the patient in the ICU and see how her ventilation recovers. And then, as Dr. Kassim said, monitor closely for signs indicating the need for a thoracotomy. So continued blood loss or massive further blood loss. But at this stage, it looks like for the time being, she can proceed to the ICU, to the intensive care unit.
Thank you, Dr. Antrach. Dr. Frisbee, Atlanta.
Go back to your schematic where you got your primary survey exposure. Those two X's represent.
Sorry. Sorry, sir. Let me get back. There we
There
go.
it is. Those two X's represent two entrance wounds.
They're the locations of the apertures. Yes, sir. So
Those are the entrance wounds.
correct.
Where's the exit?
Well, I think the entrance, I mean, we really try not to speculate on entrance and exit, but it was a single gunshot. And I think the entrance wound was here and the exit wound was here because there wasn't a bullet that was identified.
Okay. Yeah, stick her in the ICU. Let's see how she does at this point. I don't think you're going to be there very long, but go ahead and do it.
Yeah.
That's all I had.
Thank you, Dr. Frisbee. Dr. Ruiz, Ryder.
Thank you. So I think you did the right thing from the beginning, which is get the patient intubated if there was significant risk for the airway. Place your chest tubes. I think that's the right thing to do. In my case, and in my practice, I personally don't know this case, but I tend to place the access, the intravascular access, away from the site of the injury. So I would have gone with a femoral access in this case to stay away from the upper body in case there's a transmediastinal injury. You really want to have your vascular access as far away from the injury as you can. Now, once that's done, patient gets stabilized as the patient did, go to CT scan, agree on that. And then I'm concerned a couple of things on the CT scan. One, the amount of retained hemothorax despite the chest tubes. I think that needs to be resolved before you go to the ICU because there might be masking, more bleeding that is just not coming out of the chest tube. So either irrigate, reposition the chest tubes, but you have to figure out why there's so much retained hemothorax despite having the chest tubes. And now the second one is that image that you got on the internal carotid artery, which really makes me uncomfortable thinking that there might be some sort of thromboembolism through the aortic arch into the carotid that goes in through the internal carotid. And that would be a very, very high risk for a stroke, for an embolic stroke on this patient. That would be the only kind of explanation that I could have to that injury. I would love to see the reconstructions on the coronal views of those arteries to see exactly what the segment, how the segment is involved. This is pretty high up in your skull. I think this is away from us as surgeons. I think this is more into the realm of the interventional radiologist or a very skilled vascular surgeon. But most likely it's going to be something that has to do with interventional radiologist. I would really put this at the front of this patient at this point because that would be the major risk at this point for this patient. That's it.
Thank you, Dr. Ruiz. Dr. Ruiz-Pierre in Mexico.
Yes, I agree with the last comment to work up on endovascular to see if there is no thromboembolism and resolve the retain the hemothorax before facing to ICU. Thanks.
Thank you, Dr. Ruiz. Dr. Colette, Sao Paulo, thank you for your patience.
No problem. I think in this patient may become maybe not too stable because too much blood components she received. And put 2 drains in the chest is too much to collect the blood from the chest and the air. So I think this patient is maybe not too stable as I was thinking. So at the moment, this patient needs, if it continues, I need to be the reconstruction of the vascular pedicles of the carotid, subclavia, aorta, and pulmonary artery and pulmonary veins, because when it transfix this medial transfixion, the chest, sometimes injuries may become from the pulmonary ileum, and sometimes some branch of the pulmonary artery or pulmonary vein may be a problem at this moment, maybe tamponate at this moment, but they tamponate later. And so I think these patients need to be a reconstruction of all the vascular pedicles, and maybe sometimes go to, if continue sometimes stable, maybe comes to make an angio, a study of endovascular study of the aorta, subclavia, and carotida, to know what's happened with these vessels. But I think these patients may be very clear that she's going to need a thoracotomy or as soon maybe possible. It's very difficult to believe that's all the 2 drains and too much blood she has received. She's going to become continuous stable. I hope that she continues, but I believe this is not possible.
Thank you, Dr. Colette. Dr. Nedeljkovic, would you like to make a comment? Or?
Yes, thank you. I agree with what has been said so far. It is concerning to me as well, the fact that there's quite a bit of blood in the left chest, despite of 2 chest tubes. I also feel like this, basically, it's kind of zone 1, where the filling defect is in the left carotid, and then your entrance or exit or whatever is maybe zone 1. So I would definitely push for vascular to do an aortogram and find out what exactly is connecting this with the blood in the chest before we go to the unit. Now, we don't know how bullets, it definitely crossed on the other side, which is the right. I would also worry about airway and see if there's any blood in the ET tube. If it is, I would do a bronch and then also an EGD. But definitely, I think I would feel more comfortable with going to the OR with vascular to do an aortogram, make sure there's nothing else bleeding. And let's say if nothing else is bleeding, then you still need to figure out where is all that blood in the left chest coming from. So you may have to do a left thoracotomy, because if you have that filling defect in the carotid, then you're going to have to anticoagulate. She's a young patient, she's going to have a stroke. So these are my comments. Thank you.
Thank you, doctor. Anyone else has a comment? Dr. Lobb, we'll go back to you.
Okay, thank you. So thank you very much, everyone, for your comments. And actually, a lot of several of you alluded to things that would happen in the next 24 hours. We did send her to the ICU. She was mechanically ventilated, and fortunately, you know, the sequelae from the blood in the chest tubes did have minimal output, as everyone mentioned in the discussion. Though I think there was quite a bit of blood that still retained in the chest, but didn't meet the requirement for, you know, an emergent thoracotomy at that time. She didn't receive any further blood products. She didn't require any supportive pressors. So that was the same day. She came in on 8/4 in the evening. The next morning, so, you know, less than 24 hours, she was, you know, we held her sedation to get a neuro exam. And then unfortunately, she was found to have an acute change in her neurologic status with fixed and dilated pupils. So she was found to have no cough or gag response and no response to pain. She was sent for a stat CT brain. Sorry, and this is also her chest x-ray on hospital day 1. So I just wanted to point out that she actually, it had improved somewhat. But unfortunately, the CT scan of the brain, it showed, you know, diffuse cerebral edema. This is a CT, this CT actually is the initial brain CT. I just included that so you can see actually in less than 24 hours how there was a loss of visualization of the ventricles. So, you know, we sent her, so the CT brain showed edema and anoxic brain injury with effacement of the basilar cisterns. At that point, the next day, sorry, we did the carotid duplexes were done on the 5th. They weren't read till the 6th, but they were negative for any carotid artery stenosis. I think looking back, we realized, you know, probably what this narrowing of this ICA was, and I'll explain that. But unfortunately, she went for a nuclear medicine brain scan, which showed no perfusion. So she was pronounced deceased at 8:42 p.m. So this is just a view of the brain scan here. So, you know, I left and actually came in and, sorry, I actually came in because I was, you know, post-call that day, and I came in 2 days later and found out she had expired, and was just like, what the heck happened? You know, how could a patient go from a GCS of 14, have no injury to her brain, and then basically be brain dead, you know, 24 to 48 hours later. So I think a lot of you brought up, you know, concerns that we should have investigated further. But we actually were really puzzled by this, or I was puzzled by it. And so it was presented at our weekly trauma M&M conference. And then, you know, one of our senior attendings actually reviewed the imaging during the conference because it was a long discussion and everyone was quite puzzled. But we noticed something, you know, on the CT abdomen pelvis that was missed during the initial read. And I think with the, you know, the transient inclusion of the internal carotid artery at this point, a lot of people can guess what happened. But, you know, one of our attendings reviewed the imaging and saw, you know, basically on several images here, particularly in the kidneys and the perfusion to the kidneys. But I want to stop and actually ask everyone, you know, what you're thinking before I go further with what we have presumed as the diagnosis, because a lot of you alluded to it when you were giving your initial comments.
Dr. Colette, Sao Paulo.
For these situations, I think the problem sometimes the ballot, fragmenting of the ballot can go into the vessels and maybe embolization or maybe thrombus in these situations. But I don't think this, in this case, because I don't see any image of fragments of the ballot in this part.
Right.
So air embolism may be part of these injuries. Sometimes you have injuries of the great vessels on the chest. You have pneumothorax, and you have aspiration of the air from the pneumothorax through the vessels because the patient is hypotensive. Sometimes there may be air embolism, and the air embolism may become something like this. Is maybe possible, or I don't know, in one other case, maybe I think about at this moment.
Thank you, Dr. Colette. Dr. Frisby, Atlanta.
I'm going to hold my comments for a while.
Thank you, Dr. Frisby. Dr. Ruiz Pierre, Mexico.
Yes, I will hold too.
All right, no problem. Dr. Kasim, Portland.
Well, obviously you missed something. That's why the patient died initially. And we all missed something when you presented the case. You know, we thought it was just a little nick in the carotid, and the patient will recover if she goes to the intensive care, except for retained hemothorax. Now I'm beginning to think whether the injury to the transverse process of the C-spine, along with the rib fractures, and the bullet may have traversed a significant portion of the aortic structure, and perhaps not caused exsanguinating hemorrhage. Otherwise, she would have declared it herself initially, and by pouring out a copious amount of blood from the chest tubes. It looks like the right chest cavity seems okay. So I'm wondering whether she sustained some type of injury to the thoracic aorta and thereby cut off the circulation to the cerebral vascular system and hence caused anoxia and died from it. That's my guess. I don't think this is air embolism because air embolism will manifest itself with petechial hemorrhages, and you will see the manifestation of that on the skin or in the pupil of the eye, sometime in the mucous membrane of the mouth, and I doubt that. But then Dr. Collet has been right so many times. It may be true, who knows? So I'm curious myself to see. There is no perfusion to the aorta distally, almost like a Leriche syndrome, acute occlusion of the distal aorta.
I think
So,
Dr. Kassim, I believe that that's just the cut, and my apologies. It's just
okay.
it's just a thin slice. So there definitely is perfusion distal to that.
There is perfusion there. Okay. So that cannot be Leriche syndrome either. So I think most likely this is an embolic phenomenon which occluded both carotid arteries at the inception. Unlikely, but you know, sometimes weird things happen in medicine. And I look forward to hearing from you further. Thank you.
Thank you, Dr. Kassim. Dr. Antrach?
Yeah, so the one tomogram you showed of the kidney on the right side, it looked like there were some embolic infarcts, some wedge infarcts, and so suggesting that maybe, yeah, there you go, suggesting that maybe it was embolic. However, you know, she died of diffuse cerebral edema, which is not the picture you get with an infarct. And you know, an embolic infarct, you get the same thing that you see in the kidney. And, you know, that this
it's localized.
Yeah, and and then there were concerns about the bullet going through the right chest. Well, I think the point that you made is that it fractured the left transverse process of T7. Is that right? T7. So
correct.
basically, the trajectory was in the posterior left chest, and then it exited the left thoracic cavity at T7, and then proceeded in the outside the rib cage, crossing the midline in the through the paraspinous muscles, never having penetrated the right thoracic cavity, and that would have been posterior to all the pretty much to all the structures, including the aorta, which would be along the anterior to the vertebral column. So it's you know, I'm anxious also to see what the cause was. It doesn't really, I can't explain it surgically. It's and I think that's the point of your presentation, something that we wouldn't ordinarily see as a consequence of this type of injury.
Thank you, Dr. Antrach. Dr. Alex, do you have any comments?
So I think air embolism, from my training and what I know of it, it's really pretty dramatic. Happens right after you intubate, after you put chest tubes, and then it's pretty quick. There's definitely something that created feeling defect both in the carotid and infarcted the left kidney, if that's what it is, because I can scroll through. Obviously, those are just the cuts they put in there. I don't know, maybe it would be a zebra, like patent foraminovalle, and then some clot from somewhere traveled and embolized. But that's all I can think of right now. Thank you.
Thank you, Dr. Alex. Dr. Ruiz, Ryder?
Wow, what a crazy case! I promise you that I haven't heard from this about this from before. I was probably on vacation as well, but I had seen this happening before in one of my patients. It was also a penetrating trauma to the chest, a gunshot wound, high speed, huge cavity in the lung. The patient ended up in a thoracotomy and had a major pulmonary vein injury, and we pretty much witnessed how the air got sucked into the veins, which is how it happens. It gets sucked into the pulmonary artery system, which is a low pressure system, and through a patent foraminovalle traverses into the arterial system, and that patient ended up dying. And actually we were able to document the air in the coronary arteries, just directly seeing it. And I have recordings of that specific case, and this rings true to this. I think it was a massive air embolism into the pulmonary artery system through a patent foraminovalle that caused these systemic infarcts, both in the kidneys and in the brain. And the brain edema was the result of a ischemic insult, massive ischemic insult. If that's the case, I'll be with Dr. Colette and with Alex. And if I'm not mistaken, you probably probably saw this, Alex, with me at one point at Ryder. So very impressed, and I think that's the explanation. So looking forward to hear.
Thank you, Dr. Ruiz.
Oh,
Dr. Lobb?
one thing that makes the difference is the fact that the patients have positive pressure ventilation before the placement of the chest tubes, and that increases the pressure of air inside the pleural cavity and facilitates the travel of the air into the pulmonary arteries. That's it.
Thank you, Dr. Ruiz. Dr. Lobb, we go back to you.
Thank you so much for those comments. So, you know, you guys have all brought up some, you know, really interesting, you know, air embolus. What we really, based on the scans, you know, we saw, and I only included a couple of cuts, but we saw some renal infarcts that looked like, you know, the patient was showering emboli. And so we really think that there was you know, some sort of injury, whether it be, you know, from the blast injury, as you mentioned in the beginning, you know, gunshot wounds are very different than stab wounds, or there was an injury to the aorta or the heart, that the patient did have a cardiac embolism at the time of the injury. And then, you know, this CT scan that I showed of the renal arteries was at the initial, you know, the time that she went to the CT scanner. So, you know, I think we caught it at the time when it was traveling to the renal arteries when she was in the CT scanner, but believe that the emboli also traveled to the brain, causing an ischemic stroke. And that actually makes sense with this narrowing of the internal carotid artery that we saw on the initial CT scan. And then, you know, she had a duplex, granted it was, you know, a while later, but it showed no, you know, no significant stenosis or occlusion. So that would make sense if it's you know, a transient embolism that's traveling. And it's been my experience, because I actually had a trauma patient recently who came in and had an ischemic stroke at the time that he came in. That was actually the cause of his, you know, he fell, but it wasn't picked up on the CT scan. We get, you know, the CT of the brain is non-con. So it's not actually clear when the patient developed this ischemic stroke, but we think that that's what happened, that the patient developed ischemic stroke, because I mean, we really don't have another explanation. I will say that, you know, for me, in terms of thinking about this, I think some of the things that led me to not really consider this in the initial, you know, evaluation of the case is that the patient was really young. But that has nothing to do with, you know, having the occlusion is likely from, or not the occlusion, but, you know, the transient blockage was likely due from the mechanism of injury and had nothing to do with the patient's age. So I think the comments about, you know, doing an early aortogram, if we had that, it certainly would have aided in the diagnosis. Unfortunately, it seems like the complication happened quite quickly after the initial injury. So I'm not sure that there's a lot we could have done to prevent it. And I did a lot of research on this because I was like, this is just, it's maybe not unexpected, because after, you know, that's the title of my presentation, but after everyone speaking, it seems like a lot of people, you guys are all obviously experts, had this, you know, as an index of suspicion. More than one person mentioned that, you know, you need to image the heart and look at the upper, you know, the great vessels. But it's not really reported. I found one case report, and I've done some searching since this happened, but this was someone who had a cardioembolic stroke, and they actually had a blunt chest trauma 2 or 3 years prior to that, and then came in with a stroke. But this immediately happening after this initial injury, I haven't been able to find anything. You know, I know that Dr. Ruiz brought up a case that he had, so I was also interested in hearing from everyone if you have seen or heard of anything like this in your practice. But I think that this definitely changed the way that I approach these cases, in particular gunshot wounds to the chest, because I think that the mechanism alone should give us a high index of suspicion for any sort of cardioembolic phenomenon. And as I mentioned, I don't know that there was a lot we could have done to prevent the death in this patient, but I would also welcome any comments from people about anything that we could have done to potentially prevent this, or what you would have done differently.
Thank you, Dr. Lobb. So we go with final comments. Dr. Frisby, Atlanta.
Is this classified as a wound in proximity? Is that where you got your clot?
I think so. I mean, yes, that would be my guess. As someone mentioned about doing an ultrasound, you know, we don't normally do ultrasounds in penetrating trauma, but I think certainly putting an ultrasound probe on the heart at the time of the primary survey would have been beneficial for this patient. It may have given us some more information.
Well, you did a good job. I don't think you should beat yourself up for this one. This is the most rare thing that I think most of us can see. Right up there in the top 10. You did everything you were supposed to do.
Thank you.
That's all I got.
Thank you, Dr. Frisby. Dr. Kasim, Portland.
So let me get this straight. Are you suggesting the injury to the left subclavicular area caused some type of a thrombosis in the left atrium? Is that what you're suggesting?
That's what we believe. When we think it was an arterial embolus, we don't have any evidence that the patient had a PFO, but okay. Yes.
I see. Well, if it is, you know, the distance between the left subclavian carotid takeoff from the left atrium is considerable. So it is not as if they are kissing each other. This is an 18-year-old girl, right? Was she on, did you find out whether she was on the birth control pill?
I did not find that out, but that's an excellent point that you bring up.
Because I have seen one case, just like Dr. Professor Ruiz there, young patient like this comes in with a left atrial thrombus and she's on birth control and causes all kinds of havoc. But this is a very interesting case, and I think something that probably I will never see in my short expectancy of life at this stage. If I was very, very young, starting my career, maybe I will see it in the next 30, 40 years. But it is extremely interesting case. Thanks for providing this case. And I will certainly remember this and put it in my journal as one of the most interesting cases on Monday morning at the trauma round. Thank you.
Thank you so much.
Thank you, Dr. Kasim. Dr. Antrach, like that?
Yeah, so very, really a tragic case and fairly unsatisfying and not really having a definite answer. I think, you know, it's certainly possible, but I think it's perhaps a bit speculative, and why an embolus would cause just diffuse uniform cerebral edema. It just, you know, it's it still, I think, leaves a lot of questions unanswered. And someone mentioned in the chat, and that was my concern also, was there any consideration given to organ donation? Because the liver, the left kidney, the eyes, it would probably all be in the skin. You know, any thought given to that?
Sorry, that's a great question. Sorry, I didn't see that in the chat earlier. For all of our trauma patients, you know, OPO, our organ procurement, is always notified, but I believe that when the family was approached, they were not interested, and that was the reason that it was not.
Right. Okay. Yes, understood. Yeah. Yes. And also this really should be a coroner's case, I would imagine. I mean, this should really be best, especially seeing what happened. An autopsy would answer a lot of those questions. Were there signs of embolic, but still embolic stroke? It would have to be sudden occlusion to both internal carotid arteries, and to explain that, and then so probably you wouldn't see that, or you might, but it would be very odd. And then what was the source? And then the autopsy would give you the source. So really, in this case, I would have been very perplexed, and I would have first. I don't know how your coroner system works there, but I would certainly, you'd report it to the coroner or to the police, whatever, and then I would hope that the coroner would say, "Go ahead, please do an autopsy," or they would have one done, given what happened.
So we perform all of our trauma cases here are medical examiner cases. But the last I looked last night there, I didn't see that the autopsy report wasn't back yet. So I need to follow.
Okay, so she did have an autopsy. Yes, she did.
All of our trauma patients do. Yes, sir.
Jennifer,
yes,
I got a question for you. Excuse me for a minute. Do you know the caliber of the bullet?
No, we do not know the caliber of the bullet.
All right, just
no, it's a good question.
One last point. When I have patients like this, things like this happen, and I have time, I try to get down to actually, while the pathologist and the dean are doing the dissection, to actually look at the organs with them, and and see what happened. It's always been helpful, I think, when there are unexpected deaths, or even deaths that that we anticipate. But I think in this case, it'd be quite interesting to see what the pathologist says.
Thank you, Dr. Antracht. Dr. Colette, Sao Paulo.
First, it's very interesting case, because sometimes it's very difficult what's happened. We receive a patient alive and she's dead suddenly by a trauma. It's very interesting to know, to find the cases of the surrounds of these problems. I think sometimes it's interesting because you go to see the pathologist on this case. The patients go to necropsy. So it's very important to know what's happened, because it's not usually these injuries. So she may be malformations of the heart, or maybe some problems in the aorta. Maybe becomes very important to explain what's happened. I know sometimes when you have I see a patient who has a gunshot in the face, and the movement of the face, he thromboses all the 4 vessels of the neck. Okay, because there is a pseudoaneurysm, or intima discolation. The intima may be a pseudo section of the intima from the movement of the chest, and hope the intima of the vessels, and may problem with the patient. So it's a gunshot wound, and maybe the problem was the injury of the vessels. And sometimes it's very important to know what's happened, and maybe sometime maybe prevent in some case. But I think it's very difficult to know. Is congratulations to present this case. Is very, very nice case, and I hope to know what's the finding in the pathologist. Okay.
Thank you, Dr. Colette. Dr. Alex.
Yeah, as everybody else mentioned, I think the report from the pathologist would shed more light in this case. Trauma patients normally, they're maybe hypocoagulable. I'm not sure what the coagulation profile was on this patient and what other things she was on taking, or what other underlying diseases she had. We may never know, but it would be nice to find out what the pathology report says. Thank you. Great case. Thanks for sharing it.
Thank you, Dr. Alex. Dr. Ruiz, writer.
Jennifer, great case. I don't think there's any way to avoid an outcome like this in a situation like this. these things just happen. And in blunt trauma, whenever we have blunt cerebrovascular trauma and they have this carotid thrombi, it's very difficult to save the patients if they advances. Now, for sure, this was an embolic phenomenon. For sure, we don't know what type of embolic phenomena it was. The fact that you had ischemia, segmental ischemia on the kidney, confirms that diagnosis. You will have to look for in the coroner's report for a foraminal-valley communication. If there's one, I will probably tell you that it's coming from the lungs, most likely from air embolism. I think that would be the key. This is what we did in our previous case. We documented the heart defect. If there's no heart defect, then it's probably coming from the ventricle. It was probably caused by hypotension. Maybe she clotted, she had a clot in her left ventricle due to the hypotension. We don't know. How do we miss these things on the CT scan? That's a whole science. And I just had a case in which we missed an injury because we were not looking at the right thing. And remember that our job is based on stress and workload. And when that happens, you tend to focus and have tunnel vision, just like pilots have when they have emergencies in the cockpit. So these things happen. The only way to prevent from missing this is just being systematic. Every single slide in the CT scan has to be seen, even if it's away from the gunshot wound, from the trauma. You have to look at it. It's definitely a lesson to learn from this. But as to why, I think it was embolic, and knowing if the patient had a heart condition would be the key to know, or at least to make a more informed speculation on where was it coming from. And I don't think you could have prevented it anyway. Great case, excellent case.
Thank you, Dr. Ruiz. Dr. Ruiz-Pierre in Mexico, your comment, please.
Yes, this is a very uncommon presentation. And as you stated in the title, an unexpected complication. Congratulations for this session. It was very educational, and thanks for all these comments. Thank you.
Thank you, Dr. Ruiz-Pierre. Dr. Martos, would you like to do the final comments?
Yes. So thank you, Valeria, for helping to host this, to do the moderation. I'd like to say this is another important meeting. So sometimes we show some cases that go well. Sometimes we show some cases that give us a lot of lessons to think and to save the next patient. I would like you all to remember to claim your CMEs. Thank you very much. Dr. Lobb, congratulations for presenting this case. Thank you. Dr. I think you have some comments. Yeah.
Yes, Dr. Marcos and Dr. Lobb, when the pathologist report comes through, could we get a follow-up at the beginning of one of the meetings? Because, I think there may be a surprise in the pathology report. I've been astounded by some very odd findings or very unusual findings that explain exactly what happened in an unexpected death. And then right away, that nothing anyone could do. It was even God's will, and often I think the pathologist report can settle a lot of these perplexing issues. So if we could get a brief follow-up when the report comes back, I think we'd all appreciate that.
I'll be presenting another case next month, so I can actually have that information available to everyone at the beginning of my next presentation, if that's okay.
Thank you very much.
See you all next week. Thank you all. Take care.
Thanks for the case, Tom.
Thank you. Bye.